Good morning to all my respected faculties and my dear colleagues who are present here. This is a case of RA mass in a young female with recurrent pericardial effusion. So the patient was a 38-year-old female, non-diabetic, non-hypertensive, presented to us with acute respiratory distress with cold clammy extremity. BP was unrecordable, ECG showing low voltage complex, and jugular venous pressure was raised. So we did not have any confusion regarding the diagnosis and went ahead with the pericardiocentesis. Approximately 500 ml of hemorrhagic fluid was drained, which was exudative in nature, and the patient was symptomatically relieved. We kept a pigtail in the pericardial place, and for the routine diagnostic purpose, we also went ahead with all the diagnostic measures, and HRCT was done. The HRCT showed consolidation in the left upper lobes, as well as there were some areas of consolidation in the lower lobe as well, with tree-in-bud appearance. So, in view of high suspicion, although we did not had any microbiological confirmation, we went ahead with anti-tubercular drugs empirically and discharged the patient on follow-up. The patient was symptomatically better during discharge. But the patient presented to us again after 3 weeks in our OPD. Patient was apparently well, but she was complaining of exertional shortness of breath. And we thought again there might be some pericardial effusion present. We did a repeat echocardiography, which showed there is no frank features of tamponade, although there was mild pericardial effusion. But to our surprise, we also found a hyperechoic mass lesion in the right atrium. And in view of suspicion, we started her on unprecedented heparin because we thought it to be a thrombus. So this is the parasternal long axis view, which shows good cardiac contractility, and there is mild pericardial effusion. There is no features of tamponade. And this is the 4-chamber view showing the right atrial hyperechoic lesion. And 6 and APDT of 46 seconds, which was control was 23. The hyperechoic lesion did not resolve, and to our surprise, it was actually increasing in size. So this is the CT scan imaging, and the patient's shortness of breath was also increasing. So we thought there might be some pulmonary embolism from the thrombus, and we went ahead with the CT angiogram. And this showed there is, to our surprise, the CT angiogram did not reveal any inner features of pulmonary embolism, although we found there are some lesions in the parenchyma, which was suggestive of metastatic lesions. And the previous CT scan was 3 weeks before, and this is just 3 weeks later. So it's a very aggressive kind of tumor. And so we went ahead with the TE, transesophageal echo, because patient was not stable enough for cardiac MRI. In these 2-3 days, patient deteriorated further. And this TE showed there is some mass lesion compressing from outside of the heart, compressing the RA and invading into the RA, which is attached to the free wall. The Doppler also showed there is hypervascularity within the mass lesion. We would have loved to do a histopathological confirmation of the diagnosis, but unfortunately the patient succumbed the very next day. So our take-home message is, although tuberculosis is still prevalent in India, starting anti-tuberculosis treatment without microbial confirmation, it is double-edged sword. It might be beneficial and might be harmful for the patient. In our case, the patient actually will not come to a diagnosis. If we have chased further 3 weeks earlier, we could have reached to a conclusive diagnosis, but we could not. And invasive tumors of the right heart are uncommon, but it can lead to catastrophic presentations, and a high degree of suspicion is necessary to identify and treat such cases. The malignancy can progress very quickly, and close follow-up is and acting early is of paramount importance.
Yeah.
Thank you.
Very nice.